Okay, as the last members come into the room, we're going to get started. Bring around the pizza. I'd like to thank everyone for coming to November's Medical Grand Rounds. I want to thank, as always, Midstream and Iris Laycock and Piggy Dempsey here for all their work, doing all the work in the back of getting these set up and making them possible. Today, I'd like to welcome a wonderful expert and speaker that's talking about a really wonderful and great program called the Lower Limb Preservation Program. And it's Dr. Andrea Devrome, one of our vascular surgeons, supported by literally her entire department is here. So there you go. Dr. Devrome completed medical school and vascular surgery residency at the University of Calgary. She also completed a postdoctoral fellowship in clinical investigator program looking at exercise rehab program in patients with peripheral artery disease. Dr. Devrome then completed a clinical fellowship in advanced aortic techniques at the University of Calgary. And before coming to Barrie in July of 2023, she completed a clinical fellowship at the University of Ottawa that focuses on limb preservation. So no better person to lead and to speak about this important program. So let's give it up for Dr. Andrea Devrome.
Just make sure it's my mic on. Is it on? Am I on? There we go. Now I'm on. All right. Thanks very much, Chris. So thanks everybody for coming today. This is it's a pretty important issue and near and dear to my heart. So it's a bit of an amuse-bouche general description of the importance of lower limb preservation in our community and in Canada and the world in general. So my disclosures, I have no conflicts related to this presentation. There are images of patient wounds in the presentation. So if you guys have any ideas of what wound care looks like, you know, just keep that in mind as you're enjoying your pizza. All of the patients' pictures that I've shared here have provided me with permission to show their pictures. So if you do a Google search for what does limb preservation look like in images, we get sort of this is Instagram. What is limb preservation? Look at these people with their nice little feet. And I know there's a couple people who are with me in SPC today. It doesn't look like that. It looks a little bit more like this. So these are some patients that have been on my service here. And these are the patients that we're focused on here in saving their limbs and avoiding this complication. So what is limb preservation? So for the purposes of this talk, we're talking about lower limb preservation. You might hear me say LLP, that means lower limb preservation. It's an approach for saving limbs from major amputations, which I'll define shortly for you. The goal is to preserve or maintain function for people's ambulatory status. We want to preserve the appearance of the limb because people have to live with great disfigurements when they're dealing with complex wounds. And most importantly, preserve quality of life. And this requires a complex, multidisciplinary approach. So, key takeaways of this talk with any presentation that you attend, 3 concepts. Now, these are all big concepts. So an overview of limb preservation, what it is, why it's important, and how is it relevant to our community? What are we doing about it? So some key concepts. A little bit about medical risk factors. We all know them, but I'm going to review them quickly here. End-stage renal disease, smoking, hypertension, dyslipidemia, advanced age, chronic wounds, trauma, and peripheral arterial disease, which can really be all of those things above leading to peripheral arterial disease. And we're going to talk a lot about diabetes today. These are the 2 main concepts that we're going to hone in on. There's other weird and wonderful things or serious things like cancers that contribute to limb loss, but we're talking about peripheral arterial disease and diabetes. So, social determinants of health are absolutely integral to limb preservation, just as important as the medical factors of diabetes and cigarette smoking and hypertension. Men, this is data from Health Canada, men are 3 times higher of having a major limb amputation. The lowest income levels, this is not a disease of wealthy people. People who lowest completion of high school have a 4 times higher risk of major limb amputations, and areas with social deprivation have a 3 times higher risk. The rural populations have a 1.6 times higher risk of having a major amputation compared to people who live in a major center. And this is going to be relevant in this talk because we're going to talk about some outcomes and why things look the way they do here at Barrie. So just so we understand what different types of amputations are, this would be a minor amputation. These would be some targets for minor amputations. So I guess on the right side of the screen here, we can do digital amputations, take off some toes with the most distal bones there. We can even take out a ray, which those are the sort of middle long bones there. We can do a foot preserving ray amputation if a foot gets osteomyelitis. Now, if all the toes end up with gangrene, we can do a transmetatarsal amputation. Or I recently did a Lisfranc amputation on a patient just in our surgical treatment center. And these minor amputations, they can be done frequently in an ambulatory setting. They don't require OR. They can be done with local anesthetic, either with a nerve block or with regional anesthetic or just local anesthetic, pardon me. Many of our patients, when they're diabetic, they're insensate. So it actually doesn't require a ton of anesthetic. The Lisfranc amputation that I did in our surgical treatment center, she got an ankle block that I did, as well as some local anesthetic. And Danielle Amato, who's our physician assistant, was there and helping me do this, and she did a good chunk of the procedure herself. So getting her hands in there, helping save limbs. And that lady actually avoided an above knee amputation. So these are the major amputations that we're trying to avoid. A below knee amputation, they're also called a transtibial, or an above knee amputation, which is called transfemoral amputation. So peripheral arterial disease, what is it? So it's occlusions or narrowings of blood vessels. Typically, so narrowing of the blood vessels outside of the brain and heart. That's what we call peripheral arterial disease. There's a reduction of blood flow to the extremities, and it's typically caused by atherosclerosis. There's other rare causes like vasculitis or other vascular endothelial dysfunction disorders, but for the purpose of this talk, we're most interested in atherosclerosis processes. Now, it's a medical diagnosis that takes into account the patient's health. It takes into account risk factors. We use physiologic measurements. For those of you that work in our world, you'll hear something called ABI, which is an ankle brachial index, where we take the highest pressure of the arm, and it's on the denominator, the lower number, with the ankle pressure on the numerator, and ideally 1 to 1.1, that's normal. Anything below 0.9 would be considered peripheral arterial disease, and anything greater than 1.4 we can't trust. So this is one of just the physiologic markers that we use to define or confirm peripheral arterial disease. So you'll also hear some terminology called intermittent claudication. So this is pain in the legs that's reproducible. It happens the same way every time when people are walking or performing physical activity. It always happens the same way, and it improves with rest. Now, I bolded that last statement there because it's important to understand that the risk of limb loss is actually quite low in our claudication patients. And this is going to be important later in my talk. So low risk of limb loss when you have people that have intermittent claudication and are not severely symptomatic. The patients that we're going to focus on here are patients with chronic limb-threatening ischemia, previously called chronic limb ischemia. These are patients who have rest pain, so it might be refractory rest pain all the time. It may be nocturnal rest pain that wakes them up at night, so they have to sleep with their leg dangling out of the bed, or patients who have tissue loss, so non-healing wounds in spite the best wound care and antibiotic regimens. There's also acute limb ischemia, but that is not part of this conversation because that's a whole topic altogether, a different topic altogether. So, chronic limb-threatening ischemia is bad news. High rates of mortality. So it's worse than cancer, except for lung cancer. So at 1 year, 25% of patients are dead. At 5 years, 60%. And many people don't have their both limbs when they're diagnosed with chronic limb-threatening ischemia. Even if you do achieve an amputation, only the 30 to 40% of patients remain non-ambulatory after a major amputation. So clearly it has huge effects on your life, your function. Can you work? Can you get around and do your activities of daily living? It's a big deal. So diabetes, how does diabetes play in? We're going to talk, the bulk of my data is from diabetic patients in this talk. And how does it work? The common story is, Joe was out walking on his patio in the summer and it was enjoying the nice weather, and a couple of days he noticed his foot started to swell. It looked red and it smelled kind of funky. He looks at it, he's got a nail, maybe just a tack or something caught in the bottom of his foot. Now it's become a big infection. So you have this minor trauma. And that's because we have this constellation of issues with patients with diabetes, including neuropathy. So they don't feel things as people do normally. They don't have the same pain. Their nervous system cannot activate their healing systems properly. From a vascular perspective, even if they don't have big occlusions of their vessels, like their aorta or their iliac vessels or their femoral vessels, they frequently have small vessel disease, tibial disease, or even microvascular disease. And they have diminished ability to fight infection. I've already seen it 3 times this morning in our surgical treatment center, someone with a recurrent diabetic infection and they get put on Keflex. Okay, fine, that works for most of us, run of the mill, we get an infection, but patients with diabetes are affected by more microbes, and we need better coverage for their wounds. If you put them on a simple antibiotic, it will not help heal their wounds. They do not have the same defense system as the rest of us. So how do we put it together? This is one of my favorite Venn diagrams in this talk here. This is data from the United States, but it really does apply to Canada as well. So you see the big green circle is 8% of the population, of the US population has diabetes. In Canada, it's 10 to 15%. And then we have the overlap with peripheral arterial disease. And as we kind of get into the smaller and smaller circles, we see like the consequences of limb loss. And so it can tell us that 1.3% of patients with diabetes, they have limb loss per year. So the population, the numbers are pretty staggering. And I'm just going to go into our own local numbers here a little bit. So in terms of our region in Ontario, so this was published in the National Post at the end of September of this year. So most lower limb amputations in Canada are caused by diabetes. And the headline here is the hospitalization costs is $47,000 per patient, which is absolutely a gross underestimate. These are direct costs, and I have some other numbers later in the presentation that will tell you why I think this is a gross underestimation of the costs of amputations. This is just the in-hospital. This doesn't talk about the prosthetics, the help the patients require at home, the social assistance, the rehab centers, things like that. So it's expensive. So some data from Canada. So diabetes, like I said, accounts for about 2/3 of the lower limb amputation in Canada. in Canada, more than 7,000 hospitalizations per year for lower limb amputations. Now that includes minor and major. So more than 3,000 of these are the major leg amputation, and over 23,000 diabetes associated hospitalizations for wounds in Canada. So, and just a reminder here, about 10 to 15% of Canadian adults have diabetes. So Ontario data. So this is fairly current data within the past 5 years. So more than 1,200 non-traumatic amputations annually. So that equates to one lower limb amputation every 7 hours. That's pretty crazy to think, like 3 people today roughly are going to have a major limb amputation in our province. The cost that Ontario Health has published is $140 million in direct amputation healthcare costs annually. Again, I think this is the direct care. And, you know, statements from the teams here in Ontario that are passionate about the subject, they stand on the statement that 85% of these amputations are preventable, and there's data around the world to support this with the appropriate limb preservation models. So what is a multidisciplinary approach to limb preservation? So this is the approach to help preserve the limbs. What does it look like? Well, it's a collaborative effort between multiple medical professionals to help patients with limb compromise. So we're going to go through this picture in detail. I'm kidding. So I just want you to see here, see how I'm this, see right here on the bottom left of this picture, I'm that one little component there. We can see there's multiple factors, the government, the community, always with the patient at the center, with, you know, coordinators that help run all of these complex things. So what about Canada? Where do we have models that are trying to, or where do we have programs that are trying to adhere to that model? It's actually slim pickings right now so far. There's little silos and people making efforts and people running wound care clinics, but a truly integrated program, they're pretty limited. So just down the road from us, Sunnybrook, Dr. Ahmed Casey is definitely one of the leaders in our country and in our province, promoting, coming up with solutions for this issue in our province and in our country. Ottawa as well, with like Dr. Brandes and Sid Nagpal. This is where I did my fellowship, so I'm going to be talking about the program a little bit there. I'm not really familiar with the program in Sunnybrook. Dr. Casey's invited me to go down to see how they do things, but we haven't had a chance to line up our schedules yet. But I know obviously quite a bit about the Ottawa program, and I'll be talking about my experiences there. And Calgary at the Zivit Limb Preservation Clinic, which the Ontario program draws a lot of energy from the Calgary outcomes, which are excellent, which we're going to review shortly. They have a recent publication that really shows support for a multidisciplinary program and what it looks like. So first we're going to talk about Ottawa. So I was their second limb preservation fellow. They had a clinical fellow before me. I came in 2002, I guess. And the things I'm going to be talking about here was actually part of a publication that they did to demonstrate feasibility of a multidisciplinary approach. So they really began in 2017. One of the heads of the clinic is a nurse specialist, so she's an RN. She also has a PhD in epidemiology, Chris Murphy. If anyone knows anything about Wounds Canada, she's one of the people that she and Dr. Casey are sitting side by side, writing out all the important facts that we need to know and implement. There's vascular surgeons. They have fellows. I was a fellow. They obviously have a lot of residents. Right adjacent to their clinic, they have infectious disease specialists, and then obviously the trainees, and they have access to an on-site vascular lab, which we do too, which is great. We can get our vascular labs done very quickly, which is nice. So one of the things that cannot be underestimated is the physical footprint and the makeup of the limb preservation clinic. So when I wasn't in the operating room doing the revascularization procedures, I was down here in their limb preservation clinic. We can see it's sort of an emerge bay style setup where there were 4 beds, and patients would be coming in every single day. Sometimes I'd operate in the afternoon and I would see my limb preservation patients operate in the morning, limb preservation in the afternoon. And Chris was down there much of the week. So Chris Murphy, I've got a picture of her next year. So up there, that's Chris Murphy. She's the nurse who kind of ran the clinic. Those are 2 residents that I'm working with using ultrasound debridement, which is a magical tool that helps improve wound healing like nothing you've ever seen. I'm going to give you a demonstration. I'm going to give you some images of what that's like there. So this was a publication that came out in 2022, but it's data collected up to 2019. So these were the modalities of the different sort of advanced wound things that they did in terms of wound care therapy for their complex wounds. So negative pressure wound therapy, which we do a lot of that around here. Biologic wound dressing application, total contact casting, which I have yet to see here, enzymatic debridement, so using the different tinctures and substances, surgical debridement, the ultrasound, skin grafting, which they did right in the clinic under local. Sometimes we would bring in a plastic surgeon when we needed to do a skin graft. She would do a skin harvest actually she usually took it from the forearm. She would do it right under local anesthetic right there in the clinic. And then we would do amputations, ray amputations. I did a couple of CMAs down there, but I felt comfortable doing that. And I can't emphasize enough how great the ultrasound debridement was. I think they were not using it quite as much until I got there. I used it all the time. So their findings were basically it works. So the ability to develop a multi-specialist team approach for patients, it's possible. We can do this. And they have the proof of concept at a world-class institution and get world-class care based on this multidisciplinary approach. So that's great. Now, one thing that we don't really have from Ottawa yet is what are the numbers showing? Are we showing big reductions in amputations? I think that's going to parse out as time goes on. But I'm going to talk a little bit about Calgary, who does have that data. And they've been working on this for 20 years. They have a multidisciplinary group, including podiatric surgery, which I'm going to talk a little about here. This is a very hot topic in Ontario. Last month, Dr. Dukas and Becca, our nurse navigator, and our physician assistants, Karen and Danielle, and Karen and Danielle and I, we all went to Ottawa for the National Vascular Conference, which focused on limb preservation. And this was a very hot talk. It was probably one of the most, animated talks in the conference, because it was led by a podiatric surgeon, which only can bill in Alberta and maybe British Columbia in Canada, which is going to come into play in a little bit. So vascular surgery, internal medicine, endocrinology, plastic surgery, nursing is so important. We can empower nurses to do a lot with these wounds. We had a dedicated physiatry program, orthotists, they'd come to the ward. And then there's also a specialty fellow doing limb preservation there as well. So this is a 20-year project that the team worked on. And again, the footprint is very relevant. So they built a new ward. There's an ambulatory clinic right next to the ward, which is down the hallway from the OR. And you have the vascular surgeons sitting on this side. You have the podiatrists over here. So if the podiatrist got a patient, they thought, oh no, their blood supply is not good enough. Let's go talk to the vascular surgeons. They just walk across the hall. Same thing, if vascular has a bad wound, let's go see the podiatrist. They had something similar in Ottawa as well with infectious disease. And then another office in the back, we had internal medicine, and there was a vascular dedicated internal medicine team in Calgary. So what about the dollars and cents? And this is where we kind of stray from the numbers that I just shared with you about Ontario. So, and this is taken directly from their website. I took it because it's a very beautiful, they've done this nicely, and I couldn't recreate it as well. The numbers, you know, it's $218 million over the past 11 years. So they've been collecting this data. But I think the key point here is the cost. Like a prosthetic costs $7,500 in Alberta versus proper footwear. And there's so much that can be taken care of with proper footwear. These patients come in with these rotten feet. Yesterday in clinic, my guy pulled off his cowboy boot and his foot was in a plastic bag, literally. And so, you know, and he's a bit of a character, but I said, you know, can I convince you to go? He's like, well, these are all the shoes I got. I'm like, well, can I convince you to invest in a pair of running shoes just until we get this wound healed? So, and then this is where, again, the numbers kind of differ in comparing the major amputations. So and I do trust these numbers because of Alberta's centralized approach. So the average hospital stay after a major lower limb amputation, $280,000 versus a minor amputation. So like the toe amputation or even transmetatarsal amputation, $28,000. So when it comes down to the dollars and cents, it's a clear benefit to do everything we can to avoid a major limb amputation. The patients with the major limb amputations, they have to go spend months in rehab, and then they need equipment and specialist care at home. The people whose toes we take off, they walk out of here at some point. So how do they collect their data? So Alberta has two main cities, Calgary and Edmonton. And they cut the province in half. And those are the two main tertiary centers. And Calgary has the team of podiatrists. Edmonton does not. So they have a multidisciplinary team in Calgary. Edmonton does not. In Calgary, they have shown over at least a decade of work that they can decrease the diabetes-related major lower limb amputation rates by 47%. So they have numbers showing that they've actually reduced the cost to the healthcare system by more than $19 million per year. Some of the outcomes that got people a little bit excited about at the conference. So in Calgary, 26% of the diabetic related amputations are major lower limb amputations. And our cousins to the north, 58%. You bet the vascular surgeon from Edmonton who was at the conference, who saw this presented, he was the first person to the mic to say, whoa, 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 whoa. So this is again, on the left, you've got the multidisciplinary program. On the right, we have a team of amazing 8 vascular surgeons. The hospitals are actually cookie cutters of each other, very similar equipment, but there's some difference. So what is the difference? These guys, they're awesome. I did a lot of training with them. In Calgary, the vascular surgeons, some of them don't really even know how to do toe amputations. One of our fanciest aortic surgeons, I don't know that he's ever taken off a toe. And that's because these guys they do all the foot care. And these are a different sort of level of podiatrists. So they're podiatric surgeons. They've done podiatry training in the United States. They do, they got on the bottom, Dr. John Toole there. He's done 4 years of residency plus added fellowships. So he does like full foot reconstructions, nerve reconstructions. So these guys came in, and it actually wasn't any of these. None of these guys is the Zivit guy. So this was a guy who was from Calgary, who trained as a podiatrist and wanted to come back to Calgary sometime in the 90s. And they didn't have any billing. He couldn't pay his rent working as a podiatrist. So he kind of worked with the government and rallied and did all the things that he needed to do to build a future for this team. And now these guys, they don't have admission privileges. They do their bigger cases on call. They don't get dedicated OR dates, but they have this beautiful clinic that they built through fundraising and advocating with the government. So they can do all the footwork, unintended, in the ambulatory clinic. They can bring inpatients to their clinic, do it under local anesthetics. Patients don't have to be NPO. You don't have to change their medications. They're diabetic. You don't have to hold their diabetic medications. It's an overall, it's a win-win-win. So this team is absolutely fantastic. Now, this role can be taken by other capable specialists, like it's typically orthopedic surgery or vascular surgery. But vascular surgeons like to do the blood vessel work, and we'll talk a little bit about that in a minute. So there's other multidisciplinary programs or published studies out of the US, Sweden, UK, Italy, showing 50 to 80% reductions in major amputations with places that have set up these programs. So what does it take? So the Calgary program based their setup on the toe and flow model. And again, you can see I'm just that one little circle over on that far side. So it is truly a team to get these patients, to keep these patients ambulatory, to save their limbs, to save their lives, to keep their quality of life, their independence, their dignity. And every person in this little flow diagram is as important. Our wound care nurses, the patient and care partners, the primary practitioners have to be involved. So it really takes a team to keep these people going. And I know it seems overwhelming because it's hard to organize, but we know at the end of the day, there are savings for the patient and there's savings for healthcare resources. So it's very win-win. So if I were designing a program, so what is it? What do we need for something like this? You need a physician champion. Typically, it has to be someone with, the knowledge and technical competencies to be able to manage these pathologies. And then you need this whole team to kind of make it go forward. Like we need a lot of administrative support, and there has to be a community need. And I'm going to get into that just shortly here. So first, I'm going to deviate and give you a case example, because this is always the fun part of the presentation. I show you, charts and words, and this is the fun stuff. So this gentleman here, lovely guy, he's in his 60s. He was a pastor. He had a wife with MS, and he took care of her primarily. And he comes to the hospital on June 24th, and he had some ulcers, a little bit of infection. This is in the ambulatory clinic. He actually had good macrovascular flow, so his big blood vessels were working well. But he had these wounds. Let's put him on antibiotics. Shows up 3 weeks later. He's actually septic. So that's less than 3 weeks, and the deterioration was profound. On the base of the foot, that actually tunneled under the base of the foot, very close to the heel. We can see the necrosis there. So at that time, the vascular team said, okay, maybe the blood supply is inadequate. So this is a picture of tibial arteries here. So that's below the knee. There's 3 main blood vessels that we have. These aren't even that bad in the picture that's on the left here, but we can see some segments that are narrowed. They put some balloons down there and expanded them. And we can see an improvement on the pictures on the right. And this is sort of where I came into the picture. I did this amputation because he was septic and that was bad gangrene. This is kind of, we call this a guillotine amputation. We don't close it, we just open it, get rid of the bad tissue, and we worry about everything later. So that's on July 14th, 2 days after we've reestablished the blood supply. So first was the flow, now I go after the toe. So this is ongoing wound care. So now we have August 3rd. So in my fellowship, they kind of gave me free rein to use the clinic. Like I would literally go up to the ward. This guy was an inpatient. I'd wheel him downstairs myself, and I would do either a mechanical debridement or an ultrasound debridement, which I'll show you here. This is a few weeks later using ultrasound debridement. Now this is immediately pre and post. So on the left here, that's that yellowy brown tissue. That's non-violent tissue. Sometimes we call it slough. That's just fibrous deposits, cellular debris. It's non-viable. On the right, this is after I've used the ultrasound machine. It's this big machine, and I use this special wand that makes a nice noise, and it shoots out water, and that's what it looks like right after. So you can see that's a good healing bed. Now, the last picture I have for this gentleman is this wound here, is this picture of the wound here. We can see it's coming together, and this is going to heal. I never got a fully closed picture of his foot, but I mean, this is a pretty successful story. So what about our community? What does it look like? So I came here at a good time. Lower limb preservation is really hot right now. In truth, it is. There's a big effort working with the Ontario government to prioritize lower limb preservation. The one big thing I left out of one of the Venn diagrams is coronary artery disease and stroke. So we've got peripheral arterial disease, we've got diabetes, we've got coronary artery disease, and we've got cerebrovascular disease. So, and all of these things kind of overlap. So what does the data look like in our community? So this is some data used to promote our lower limb preservation project with the Barrie Ontario Health Team. Shout out, they're here. And one of the things, I have presented this once before at another presentation here, so some of you guys may have seen this slide before. So these are lower limb procedures in our region. The time frame was the fiscal year 2023 to 2024. The first image is major amputations, and this is the numbers per 100,000 adults. And in terms of major amputation, we can see that we have one of the higher numbers, second highest. And having the highest number here is not a good thing. We're fairly average when it comes to minor amputation, and we're fairly high when it comes to lower extremity revascularization. Now, the last time I presented this slide, people say, why is that? Why are we doing so many major amputations? And I think I presented this data about 6 months after I started here. I'm like, I have some thoughts, but I mean, some of the stuff we talked about early on in the presentation, high rural population. So we're a central area for a big rural community. We have got a lot of patients in rural areas that don't have access to the major centers. So all of those social determinants of health play into this, absolutely. And same thing with, on the far side, the revascularizations, that goes hand in hand. So we have the incidence of peripheral arterial disease and patients with diabetes requiring revascularization. It's very high in our community. So Core Health Ontario, which is an organization kind of, I think, founded in the cardiac space and the stroke space, and seeing how it all overlapped with the vascular and vascular disease space. They kind of worked with communities to come up with a multi-year lower limb preservation strategy. I think Core Health itself is kind of absorbed by Ontario Health, but this is the team that we're working with our Barrie Ontario Health team, with the goals to reduce avoidable, non-traumatic major lower limb amputations and improve equitable access to high quality, best practice, early screening, cardiovascular risk factor modification, and integrated lower limb wound care. That's obviously taken directly, that's a quote from the Journal of Wound Care that published this project. So we have this amazing program that I've been working with. It's the timing of my arrival here was fortuitous for me, hopefully for them, as I work with them as a clinical lead and providing input in providing proper foot care services. So we see patients that don't need a referral, and we assess their feet if they have risk factors such as diabetes or peripheral arterial disease. It's no cost to the patient. It's a great program. We're loaded. We're loaded in terms of the number of patients we see. There's bumps. We're navigating our way through the bumps in terms of location and equipment and things like that. It was a fantastic program with an excellent team. So we've got some momentum, but is it going to move the needle? Will our current efforts reduce the rate of major amputations in this community? Well, absolutely, unequivocally, no. And if you remember way back at the beginning of the presentation, I talked about claudication patients. They have a 1% risk per year of amputation. So that's the patients up here in the white. Okay, so they're the cheapest patients in terms of healthcare cost. They have good function and they're at risk. But that's not where we need, like that's where we're focusing some energy. We need to focus on these patients. And that's where we have some growth. So some uncomfortable truths, in my opinion. This is my editorial here. So with everything we know about major amputations, why don't we just do the wound care? Why do we proceed with so many major amputations? So limb preservation, it's hard, resource intensive. There's a personal cost to the patient. They have to drive, they have to pay parking, they have to have equipment around their house, they have to buy, they can't use plastic bags of socks. And it's a lot, and it's a lot on the family. The family have to bring their family members in. So it's a huge cost to the family, and it's exhausting. This is a full topic in itself, but physician reimbursement is a real thing. You can go look at the billing codes. So I can't ever complain about a salary by any means, but earning is part of it. And that's where the model in Calgary really overcame it because of the huge volumes that the podiatrists can see. They see 40 to 50 patients per day, and they do procedures. I can see about 15 down in STC. And for example, a debridement that reimburses me, let's say about $30. My patient who kind of comes in and then we have the whole thing. It takes about 30 minutes. I pay $30 for that. That's barely lunch for 3 at McDonald's. Or a baloney amputation. They're paid about $300. Go into the surgery. Takes about an hour. Tuck them in on the ward. They can go back to their own community. Something happens. They go away. I don't have to see the wrong foot anymore. Another limitation is the technical surgical capabilities. So to do some of this fancy stuff, it takes some training. These podiatrists were well trained, and I was well trained by them. And there's more vascular surgeons and orthopedic surgeons who are getting trained. Sometimes people just want to be done with it. So they don't want to see it anymore. So moving forward, we're building a foundation for an excellent team. So we've got a good launching point. With our Ontario Health team, we've got 4 fantastic vascular surgeons that I'm working with. I know I've communicated with the orthopedic team. We need to keep advocating for resources, collect data, follow the numbers. We need to see how much this costs and how can we make an impact. And then I know I was showing data of all these fancy centers, Calgary. They've got all the oil. They have Daniel Smith. They've got Stephen Harper, just lives up the street from where I was from. So this is my new little inspiring, building a scalable diabetic limb preservation clinic, 4 steps to success. So stay tuned. So we build it, they will come. Thank you.
Yeah, I want to thank Andrea for a wonderful presentation and open up for questions. I'm just gonna, I'm gonna give the microphone. Anyone have any questions for Dr. Devrome?
I was just wondering why you think, or do you know why the rates in Canada for diabetes are higher than that of the US? That's going to see.
So it's probably not real. So it's probably a diagnosis thing. So we say 10 to 15%, there's probably a number living undiagnosed. If we think of the US and the access for people to healthcare, it's probably they just don't have access to the diagnosis. So there's probably, Texas probably takes up, another whole like 3 or 4%.
Any other questions for me?
Thanks, Dr. Devrome, great presentation. I'm just trying, like, is it ortho that does the amputations? Is it combined with vascular? Is there always collaboration between the two services?
I think it's a to be determined situation. So we've started that, like Dr. McKenzie and I had another patient presentation. The guy gave me all the images. I just didn't have time to put it in here. It was a guy that Dr. McKenzie and I did together that Dr. McKenzie saw and was like, oh, I think this might be an amputation. And I saw him. I said, well, I think we can try and rebuild the foot. So we actually did the case together. We've rebuilt the foot and we're seeing very good results. In one of my presentations, I will present images. He's almost fully healed and we're able to just do a selective ray amputation of his foot. It's not a perfect solution, don't get me wrong, but and I've been speaking with others like Kelly Stevens and I, we did a transmetatarsal amputation together. We need to kind of figure out who the players are, who are the technicians as we build this going forward.
When they do the prevention, so it becomes a less of an amputation and all recovery, do those patients come back for amputations later, or do they sort of educate to prevent future?
So yes and yes. So I always tell people that when they meet me, it's a lifelong relationship that we have. And I had this conversation with a patient today that we're going to see improvements and we're going to see deteriorations. These complex wounds, they're never healed. They're closed. And that tissue is always vulnerable for their breakdown. So sometimes they go on to progress. But when you have a system by which they can say, uh-oh, things are starting to look kind of funky, and they can call, they say, hey, Andrea, things aren't looking so good. I'm like, I'll see you, and we'll do a little scrape. We'll give you some antibiotics, and then we can get them back to wherever they were. And hopefully avoid emergency and admission to hospital and major amputation.
Thanks, Andrea, so much for this. And all this hard work that you've done on the Devrome preservation program. Right when you joined Ontario Health, they just kind of put this together for highlighted 13 centers in Ontario, and we were fortunate to pick this one. And the Good Foot Forward program has been highlighted at multiple meetings for its success. And I think what you highlighted so great in the presentation is how much this helps patients and how it lowers amputation rates. And the secondary portion is the cost analysis and how this helps not only the hospital, but provincially in funding. I think another piece to just kind of tack on is how it helps all services in the hospital. Because I think a lot of patients will come to the emergency department with a wound. And I saw some of our emergency physician colleagues in the back, and I think it is difficult and challenging for where the patient should go for follow-up. Family physician and education on wound care, I think, is sparse throughout. And so they don't really have a place to go. Sometimes these patients are admitted onto the medical floor for weeks of IV antibiotics, and surgeons are slowly or quickly consulted to get involved. And we have Corey, who's an excellent wound care nurse at RVH, where we are down to just one, and he runs off his feet every day seeing patients like in the hospital. So I think this is also where, like, a wound care clinic here at RVH would be beneficial for patient care and flow, and also to offload admissions and revisits to the emergency department for antibiotics and debridement, etc. So more kind of a comment, but thank you so much for the talk and all your hard work on this.
Thanks, Joel. Yep, that's bang on. And we actually have a team that we've been talking about pulling the numbers, like what are the, we haven't done this yet, but basically collecting that data, how many patients are going to emerge for complex wounds and what are the admission rates? So.
Are you feeling on thick with all the last research at once? Can I see those Ontario numbers that you had by region or something? I'm just wondering, does the government like how useless this breakdown of the information, because but like you said, this is pretty much just flying blank, right? Like for the social like determinants of your amputation rates that we know, like this, you just don't know when it changes from year to year, you know, what change. Are there more old people, are there more poor people, are there more diabetics, like, or it just, and the things that can shift these numbers, you know, so first of all, what are we using these numbers for? Are we trying to see like the success of vascular surgery and lung preservation programs? Because I think you should be trying to control for every factor other than that. And most of the things that we know decently well in the population are what we can't control for. But like for that, that's like impossible to say just because, and there's over time demographic factors. So if you're hoping that, oh, we're going to do stuff and bring this down, this is what diabetes is doing. Like if we stay as good as we are, these should all double. And so on, you know. So don't expect the curve to go down and that to be successful. That's my thing. I'm showing ours. Like what is improvement supposed to be? What am I aiming for in 2 years? Do I need to be like better than Ottawa OHT and like, or like are we all going to be dull? And
I know, I love this slide, and the Ontario Health team looks like they've had to go, but it's, I had the same sort of response to this slide, because like, are we taking the actions that we need to take to hit the target? And that's where I said equivocally, no. I really, the absolute numbers are going to go up, but hopefully the percentages can go down. So like, but for sure,
how many diabetic, but we don't even know that.
Yeah.
This is broken down by diabetics or age in your population.
there are further breakdowns. This was just a little highlight slide. So there's more data around this that I didn't include in this. Yeah.
Devin was headed up.
Thanks. So just a question from a clinic's perspective. What point should we keep vascular surgery involved for consultation, whether in inpatients or outpatients? Because at the risk of failing the clinic, every diabetic foot ulcer.
Absolutely. So that's a great question, and it's been on my to-do list to get to know you and your team a lot better, because this is where we can really work together. When do you call us? When you're worried, and we can take it from there. We're here to be consulted. So, and we might be frustrated and irritated at a black toe, probably. But so be it. That's what we're here to do. And we can say, we'll see it in clinic, or we'll see it in STC, or we'll see it when I get around to it, or call me before you discharge them from the hospital, or when you know when to be worried. You know when, like, uh-oh, this is not going well. Patient's septic, or they can't move their foot and they can't feel the foot, or whatever. So I do think our teams need to work together, because again, that's part of the multidisciplinary approach, and we need some champions from your guys' world as well, because this is all about cardiovascular risk reduction as well. It's all the same cocktail. And then we're the technicians that kind of do the plumbing and then the, debriding.
Just having Tiana's question, the forward program, self-referral, correct?
Yes, yeah.
So if you wanted, let's say you have some news, you can review for that reason and say, hey, call this out when you go home.
So here's the thing. So that does happen. The Good Foot Forward program, though, is the lowest lying fruit. Like, these are patients that don't have complex wounds. They have a triaging form that says you're eligible. So if you have a black toe, they say no, you go to Emerge. So it's again in that final image that I showed. It's really the people in the top left corner who are being seen by the Good Foot Forward program because of a myriad of factors. The goal of the Good Foot Forward program is to get into the community and partner with community members, and it's more preventative, which is a hugely important aspect of this, and educating patients and giving them access. We created a mechanism so that if they get a patient that's like, uh-oh, the team has my number, they can call me anytime, anywhere, any place, and I will help with a patient. And we also have Dr. Jackie Lai, who's a family doctor, so because I can't take a referral directly, so to make that happen, we contact Jackie and then he refers to me.
Hi,
I'm Amanda, one of the nurses from the adult diabetes team. I just wanted to hop in and share because it sounds like maybe not everyone's aware of her. But this is Emily. She's our resident chiropodist. So when I'm looking at feeding our outpatient diabetes, like I'm looking at them going, oh, would this be appropriate for our Good Foot Forward program where it's more supportive with the stuff, things like calcium and health care, or ooh, is this one that Emily should see? And then from there, if I still have concerns, I let my endocrinologist know, and she may refer to a muscular at that point in time. So I just wanted to share that that's another option as well. So if you're looking at referring to an outpatient setting for someone with diabetes, chiropody is good.
That's amazing. I think you just highlights like when there's so many good resources that like, unfortunately like, some of our care providers are still like, I don't know all the options. And it seems like there's multiple pathways to the same street. And so I think the clarity of that would be really helpful because it tells you can get into a bunch of advice you get into this country.
Exactly. There's like I said, there's the dabblers, there's the silos, I'll do a balloon clinic. And Emily's part of the Good Foot Forward program as well. So we're trying to integrate things and build.
So actually, it's part of what I wanted to talk about. You talked about social determinants of health. We all know how that is a big deal in elevating healthcare. So your clinic, do you have access to social workers, dietitian, occupational therapists that would, like we said, help the physicians in the ICU, they explore the diabetic clinic and do the legwork for you so you don't have to make a one connecting with family?
No. And I don't really even have a clinic. Like we have our program, our Good Foot Forward program that we've started that is sort of tenuous. It's really a program it's like what Joel you call it was like a concept, like it's a proof of concept program for limb assessment. But no, it's very like there's Emily, and then we have Kim, who's like a nurse, and then we kind of we're just trying to figure it out from there. So, this has been a year and a half of kind of seeing all the data points and what are the big questions and what are the big concerns and what are the goals and what are the needs and what can we feasibly put together outside of a major tertiary center that would help our community. Like it's never going to look like Calgary, it's never going to look like Ottawa, but what is something a little bit more centralized, like you're saying there, what does that look like in Barrie?
I think that's what we were hoping to do with this talk today is bring attention to the issues and bring hopefully some like-minded individuals into the room, because building this food clinic here at RVH, I think has nothing but benefits to patients, physicians, support staff. It's just centralizing it and bringing everyone to the same place. Because just as you all highlighted, how many people are involved is a lot less. And the more people we can bring in a centralized location, the better for patient flow and outcomes that we'll have.
Perfect. One more question, last question.
Just a quick question for chiropody. Can we put an order in for chiropody to come and see a patient in? Because we were told that we couldn't anymore because they were not available and. Awesome. Thank you.
Okay, I would want to thank Andrew both for all our hard work and dedication. This is stuff that we're passionate about, something like this that this doesn't get paid for. This is all on like personal time and the efforts and coordinated teamwork to do something like this, which is going to make a huge difference to our community already has. So first I want to thank you for that. And second I want to thank you for a wonderful presentation, sharing a lot of great questions and hopefully as Joel alluded to, like some coordinated change and support. So everyone, thanks so much.
Thanks so much.